Students, today's class is important. It is on the anatomy of the inguinal canal. We need to know the anatomy of the inguinal canal to understand how inguinal hernia takes place. And inguinal hernia is the most common of all hernias. In fact, 75% of all hernias are inguinal. So, coming to the anatomy of the inguinal canal, the inguinal canal is an oblique passage and it lies between the superficial inguinal ring. Now this superficial inguinal ring is lying here. It's an opening in the external oblique aponeurosis. So it lies at this level. And this canal extends from the superficial inguinal ring to the deep inguinal ring, which is an opening in the fascia transversalis. So this is the fascia transversalis. So this line is representing the fascia transversalis, and this is the oval opening in the fascia transversalis. So from the deep inguinal ring to the superficial inguinal ring, this passage, this oblique passage, which is about 4 centimeters long, is called the inguinal canal. So, what are the contents of the inguinal canal? We have got the ilioinguinal nerve and the spermatic cord in males, which is replaced by a round ligament of uterus in females. So, ilioinguinal nerve is the common content of the inguinal canal in both sexes, while spermatic cord is present in males, and instead of spermatic cord, the round ligament of uterus is present in the females in the inguinal canal. So these are the normal two contents of the inguinal canal. Now the deep inguinal ring, see its location is lateral to the inferior epigastric artery. So this inferior epigastric artery is a branch of external iliac artery, and the deep inguinal ring is a gap in the fascia transversalis lateral to the location of inferior epigastric artery. Now this figure is showing you the anterior and posterior boundaries of the inguinal canal. This is a horizontal section. So one can make out that the anterior wall of the inguinal canal is made up of the external oblique aponeurosis in the whole extent, while in the lateral 1/3, the fleshy fibers of internal oblique are also forming the anterior wall of inguinal canal. The posterior wall of inguinal canal is formed by the fascia transversalis, and in the medial 2/3 it is also formed by the conjoint aponeurosis or conjoint tendon, along with the reflected part of inguinal ligament also on the medial side. So posteriorly, the inguinal canal is formed by the fascia transversalis in its entirety, along with the conjoint aponeurosis and the reflected part of inguinal ligament. So, skin, superficial fascia, external oblique aponeurosis, they form the anterior wall of inguinal canal, and in the lateral 1/3 by the fleshy fibers of internal oblique, while peritoneum, extraperitoneal connective tissue, fascia transversalis form the posterior wall in the entirety, along with the conjoint tendon present in the medial 2/3 of the posterior wall, and then on the medial aspect also lies the reflected part of inguinal ligament. This structure is the spermatic cord, and this is the testes. So the spermatic cord is passing through the inguinal canal in males along with the ilioinguinal nerve. The spermatic cord is replaced by the round ligament of uterus in females. Now this is the sagittal section, so it is showing the roof and floor of the inguinal canal. The roof is formed by internal oblique and transversus abdominis, while the floor is formed by the inguinal ligament. So one thing we must appreciate here is that the internal oblique muscle is coming in the roof of the inguinal canal, and then again the internal oblique is coming in the anterior wall of inguinal canal as well as the posterior wall of inguinal canal. We'll come back to this again. Contents of the spermatic cord. So if we take a section of the spermatic cord, we see that there is the external spermatic fascia on the outside, cremastric fascia on the inside, this external spermatic fascia is in continuity with the external oblique aponeurosis. The cremastric fascia is in continuity with the uh, internal oblique muscle, while the internal spermatic fascia is in continuity with the fascia transversalis. So what do we see in the cut section of the spermatic cord? We find the main content is the ductus deferens. Then there are three arteries: testicular artery, cremastric artery, which is a branch of inferior epigastric artery, and the artery to ductus deferens. We have got some nerves here. So what are the nerves? Genital branch of genitofemoral nerve, it supplies the cremastric muscle. Then we have some sympathetic nerves which are present. Then we have the lymphatic vessels from the testes. We have the veins here, which are the pampiniform plexus of veins. And then we have the remains of processus vaginalis. So these are the main contents of the spermatic cord, which a student should know. Now, mechanism of the inguinal canal. So normally the inguinal hernia is resisted by these mechanisms. So the inguinal hernia takes place when the intra-abdominal pressure rises above a certain level. Now, there are mechanisms to prevent this development of hernia, and there are seven mechanisms. One of them is the hormones of our body, and then we have these fancy names, flap wall mechanism, ball wall mechanism, slit wall mechanism, shutter mechanism, and guarding of superficial and deep inguinal rings. So let us see what these mechanisms are. So again, in this diagram, we can make out internal oblique is present in the anterior wall of the inguinal canal, as well it is contributing to the posterior wall of the inguinal canal. In the sagittal section diagram, we saw it is contributing to the roof of the inguinal canal also. So internal oblique has got a triple relation to the inguinal canal. So when this muscle contracts, so the mechanism is like the shutter of a shop closing. So internal oblique approximates the inguinal canal and prevents the development of hernia. Other mechanism is the external oblique aponeurosis. The crura, when it contracts the external oblique aponeurosis, the crura, they approximate to each other, so they also try to prevent the development of the hernia. This is known as the slit wall mechanism. Then we have a flap wall mechanism, which is due to the different levels of the superficial inguinal ring and the deep inguinal ring and the obliquity of the canal. So when the intra-abdominal pressure rises, the anterior and posterior walls, they try to approximate to each other due to obliquity of the canal, and this is called the flap wall mechanism of the inguinal canal, which resists the development of hernia. So we have done shutter mechanism, slit wall mechanism of external oblique, and we have done the flap wall mechanism. Now we see here again the guarding. We can see that the deep inguinal ring is guarded by the internal oblique muscle, while the superficial inguinal ring is guarded by the reflected inguinal ligament and the conjoint aponeurosis. Other mechanism which is there is that the contraction of the cremastric muscle makes the spermatic cord move up and it plugs the superficial inguinal ring. So this is called the plug mechanism. So the cremastric muscle contracts, so spermatic cord plugs the superficial inguinal ring and resists the development of hernia. So these are some mechanisms, fancy names have been given, which you should know, and these mechanisms are the factors which resist the development of the inguinal hernia. So this slide just highlights the importance of the inguinal canal in males. This inguinal canal is larger in males compared to females because of the descent of the scrotum, and the males are more prone to development of inguinal hernia because of the larger inguinal canal. In the females, the femoral hernia is common because of the small femoral vessels and the wider pelvis in females, while in the males, the inguinal hernia is more common because of the wider inguinal canal in males. So you can see the text, you can read the text of my lecture today. It is available online when you visit www.buzzdesire.com. So this whole book is available online and you can go through it. So I thank you for your time. Next class I will take on inguinal hernia.